All right. Welcome, everybody, to the ACLC webinar. We are so glad to have you with us. This is Tom Merrill, your usual moderator. Today, I'm just going to be welcoming everyone. We have a special moderator for today's webinar, which is entitled Convenient Care, How to Leverage and Utilize a Telehealth Approach. Very excited about today's webinar and glad you are with us. Before we get started, let me do some housekeeping. So as a general rule, mute your line so we don't hear any feedback. If you're using both a phone and a computer, it's best to dial in first, then through your computer and select the connect via audio option. When the window pops up, then mute your phone. So let's just keep the audio as clear as possible. Before we jump in, a couple of announcements. So the agenda, just real quickly, is we're going to cover some updates. We will turn the time over to Karen Bell, who is our moderator today, and a voice that you all know, being that she oversees our HIT work group and has done a lot of good work there. She will introduce the guest presenters, who are Daren Anderson of the Weitzman Institute and Dr. Julie Lin, and then we will finish with a 10-minute Q&A after they are done. So we'll just tell you that you can submit questions ahead of time by using the chat box, the chat box functionality in your Zoom window. So, or if that isn't immediately apparent how to use that, shoot us an email. I think it's members at accountablecarelc.org. Sorry, and we will get your questions that way, and we'll submit them to Karen for the discussion. So we have a political webinar coming up with our chairman, Mark McClellan, and Governor Mike Leavitt on May 31st. I don't believe that was on the original calendar. This is a newer event that we're excited to host for you, and being that there has been quite a bit going on in the political realm, we think it's a really relevant time to discuss some of that activity. So in May, we are already 9 or 10 days into May. Work group calls have been happening. If you are unaware of those invites have been sent out, but if you're unaware of those meetings, just get in touch with us and we'll make sure that you're on those. And you can reach out to Daniel Chipping or the members email I mentioned earlier. So, and we know this is really far in advance, but you are all very busy. So the ACLC member meeting is in DC on October 3rd and 4th. Details of that will be forthcoming, but please block out your calendars. We would love to have you there. These have been very exciting and substantive meetings, and we'd like to count on your participation. So without any further ado, I will turn the time over to our esteemed HIT chairman, Dr. Karen Bell. Karen, are you there?
I am more than there and ready and very excited about today's meeting because I think we can talk about telehealth for hours. We only have an hour today, though, so we're going to keep it focused on a very special aspect of it. Well, before we start, though, I would like to just run through the different types of technologies that actually would be considered in telehealth, and those are on the next slide. The first of these is the one that I think everyone is probably most familiar with, and from the traditional telemedicine model where a provider or a clinician can care for another patient in another setting. It's expanded quite a bit. It's not just about direct patient care now. It also includes multiple patients, such as a tele-ICU or case conferencing, such as the ECHO program that you'll hear a little bit more about later, and educational opportunities. Remote patient monitoring is interesting because a lot of PCOs are currently doing that as part of their care coordination program. And this is where, as you know, a number of physiological parameters are collected, analyzed, and when there's an aberrancy that requires a clinical intervention, it's referred on to the patient's clinician. mHealth is becoming a new wave, and maybe even a tsunami, of all types of apps, and possibly even avatars. And it's on our doorstep right now. I think the father of mHealth is a dermatologist, actually, Dr. Joe Cavada. and he has recently written a book called The Internet of Healthy Things, which might be interesting for any of you who are particularly focused on the health approach of telehealth. And then we have robotics that started actually with NASA when it was used to do basic level surgical devices, using basic surgical devices that could be implemented and managed, manipulated externally and virtually, and now extends to medication dispensers. So robotics is an up-and-coming area of telehealth as well. But today we're actually going to focus on the second one that's listed on these slides. Store and forward is the time-honored name for a delay in interpretation or a delay in care from when the transmission first occurs. But I think the more prominent name now is asynchronous telehealth. And this is becoming really, I think, even more important as a result of a number of ACOs beginning to take on downside financial risk, because a lot of the cost of care is in specialties. So the use of store and forward or asynchronous telehealth to use specialty care more effectively and more efficiently in a cost-efficient way is becoming, as I say, quite important as we move forward. Before we get into today's talks on store and forward, I do want to acknowledge that there is a very large elephant in the room, and that elephant is called payment, reimbursement. Very different for different payers and very different by state. So rather than go into it in detail today, I just want to refer everyone to two sources. One is the American Telemedicine Association. That's www.americantelemed.org, which has a lot of information that may be referable to whatever area you're in on reimbursement. And also, HRSA funds a number of telehealth resource centers. There are different states in each one. And again, if you go to their website, which is telehealthresourcecenter.org, you can learn more about what is actually happening in your own state. So with that, I would like to now turn this over to my colleague, Daren Anderson, who is the director of the Weitzman Institute, who will do I think, a very interesting presentation to you on the value of this, particularly in the ACO setting, and then we'll follow up with some actual work that's being done at a large academic center up in Vermont. So, Daren, would you take over now and share your thoughts?
I'd be happy to. Let me just switch over to my share screen and I will jump right in. Karen, thank you so much for teeing this off and framing up what I'm going to talk about today. And let me thank ACLC for the opportunity to present my story to you. And I would like to tell a story. And it's a story that really starts from my own roots as a primary care provider. I'm a general internist, and right out of residency, I started working in a federally qualified health center. I was in the National Health Service Corps. And I went from a robust academic environment where I had every specialist right down the hall that I could talk to and run cases off of, to a clinic that geographically wasn't far away at all. I was in the state of Connecticut, but where access to specialty was suddenly almost completely cut off, and immediately began facing great difficulty in when we had patients that needed access to a specialist. And so as my career progressed, I became more involved in the administrative side of Community Health Center, and ultimately became director of an entity that we've created called the Weitzman Institute, which is a learning and innovation center that tackled this particular issue in particular, e-consults and store and forward technology, telehealth, Project Echo, looking to find solutions for our health center, large F2HC and others around the country that would help address these and other issues, like how to make the transition from volume to value, how to support workforce development and train people to the next generation of primary care delivery. But the entire project that I'm going to talk about in the story I'm going to tell you starts with an email like this. And this is a real email that was sent to me in June of 2012. And this is from a referral coordinator. We have a centralized referral team that anytime a primary care provider requests a referral, the referral coordinator has the unhappy job of trying to find a specialist in the state of Connecticut that would be willing to see that patient. And the vast majority of our patients have Medicaid or are uninsured, and so that is a daunting task. And as this email states, she lets me know that Dr. So-and-so of Yale Orthopedics says that all orthopedic referrals from the Shoreline area, where this consult was coming from, are to be scheduled locally, i.e. don't send them to Yale. If nobody will see them, you can send them to UConn. From where this consult was being sent, UConn was an hour and a half drive away for an uninsured patient or a Medicaid patient who may well not have easy access to transportation, the ability to get up to UConn. Goes on to make the similar story about a dermatologist locally who would only take patients with Medicaid from certain towns, and this particular patient didn't come from any of those towns. And so I think her poignant words, for me, this means I have nowhere to send a managed healthcare patient when they need to see an orthopedic. As for dermatology, patients from Waterford have no place to go. Can my job get any harder? Question mark, multiple question marks. The background behind this is that this type of experience, this type of problem, was not unique to us in Connecticut. In fact, it exists across the country. It exists in rural areas, it exists in inner cities, because we know that not just in FQHCs, but really in primary care in general, 1 in 4 visits results to a primary care provider result in a referral to a specialist. And these imbalances that email demonstrates actually contribute to lots of bad things. Increased utilization of emergency rooms, greater morbidity and mortality, and it is one of the major contributors of ethnic and racial healthcare disparities. So we started thinking at Community Health Center and at the Weitzman Institute about the exchange of information that was going on when you sent a patient to a specialist. We started thinking that there's a significant number of times when a primary care provider indicates or requests a referral that what they need is knowledge. They may not necessarily need the patient to be seen, prodded, palpated, talked to, procedured. That many cases we're looking for advice and guidance. And so we created this concept that I call the moving knowledge pyramid. And it's really our conceptual model that when a primary care provider needs a consult, there are a variety of ways that their request can be resolved. And as Karen already outlined, e-consult, store and forward, is one of those elements, and we believe is the foundation in terms of scale and in terms of the types of questions being asked. That e-consult can probably handle a significant % of those requests. Project Echo is an ongoing telementoring intervention that trains primary care providers to manage topic areas that they otherwise wouldn't. And then telehealth doesn't do much to increase access in that if you have scarce resources, you still require 1 specialist and 1 patient, but certainly is part of the solution. And hopefully at the very top is the face-to-face visit. So here is an example of how that same orthopedic consult is done now in our health system in Connecticut. And I'm not going to read through this, but what it tells you is about the story of a 32-year-old man who has an ACL tear for 4 years and has been getting steroid injections, but really wants to see a surgeon to get surgical repair and doesn't want to do any more physical therapy or anything else until he sees a surgeon. And the response, just to summarize, the surgeon points out that after 4 years, a surgical repair is not a consideration, it's not possible, and won't solve the person's problem, no need for surgery. He does say that continued cortisone injections may be appropriate, but need to be done on a fairly regular basis, and also informs the primary care provider to get an MRI, whereas the patient and the primary care provider had been planning to do so, and strongly recommends quad and hamstring rehabilitation as the cornerstone to improve his knee. And as you look through this, I think you can see, not only did we help address an access issue. This is one of those patients who would have had to travel an hour and a half. There was a 6 to 9 month wait to get into orthopedics at UConn. This issue was now the information was exchanged with the primary care provider who could then act on the plan. And I'm sure those of you with a financial background can see the money that was saved from this consult. An MRI was prevented, a referral to an orthopedic was prevented, and potentially an unneeded or unuseful surgery was prevented as well. So we decided to test this concept and to explore it and really see if we could find out in a more robust way, what was the impact of a model like this? What was the impact not only on clinical care and clinical outcomes, but also on financial outcomes? And so we did a randomized controlled trial which you can read yourself in the Annals of Family Medicine. It was published in March of last year. And basically, we randomized all of our primary care providers across the state of Connecticut in our health system, and half of them got access to a new e-consult system for cardiology, and the other half didn't. This was a prospective cohort randomized controlled trial, and we followed all the patients that got referred for about a year, and with subsequent 6 months follow-up after the consult. The primary care providers could, this is a screenshot from our electronic health record, they could attach, or the referral coordinators could attach documents, they could attach photos, they could attach EKGs, referrals, and the clinic note would be sent over. And the specialist would log on to a web-based system, would review all of those documents, and would type their response, and that would get conveyed right back into the EHR. And this is what we found. We found that 69% of all consults that were made by the providers in the intervention were managed electronically with no need for a face-to-face visit. And 31% the cardiologist reviewed the case and suggested that a face-to-face visit would be appropriate. And even in those cases, many times they would provide advice about the appropriate workup that should be taken, or the appropriate test that should be sent along prior to the visit. So even in those cases, often they were able to augment the benefit of the face-to-face visit by making sure the patient was seen and had the appropriate information at the time of the consult. We also were able to get claims data. The vast majority of patients in the study had Medicaid insurance, and so we got a full claims file set from our state Medicaid provider, and we're able to analyze it. And without going into all of the details, both unadjusted and adjusted cost per case, we found two interesting things: that the cost attributed to cardiac tests and procedures was lower in the group that had the e-consult, and that total cost of care was $486 less in the group that got the e-consult compared to the group that got the face-to-face consult. And this was with an intention to treat analysis, which is the most robust and conservative approach that we could take to this data. And so we're quite confident that these really reflect savings to Medicaid. And it's most interesting because in our state, Medicaid actually reimburses a cardiologist less for a face-to-face visit than they do an FQHC like us. So the savings did not come from the prevented face-to-face visit. The savings came from all of the additional costs that are attributed to cardiology visits that we prevented by doing the e-consult. And to show this graphically, I'll show you, these are the cost curves. You can see the two groups. Dotted line represents the face-to-face group, and the solid line is the e-consult group. And you can see the line in the middle is the date on which the referral was made. And although the costs were equivalent for the entire 6 months prior to the consult, the minute the consult was sent, there is a divergence in those curves. And the costs for the face-to-face group went up, and the costs in the e-consult group actually remained steady. And that equated to $486 in savings per patient across over a 6-month time period. That's a very, very rapid return on investment for a Medicaid department that is not rolling in money and was very excited to find anything that would produce potential savings. And so as a result of these findings, Connecticut Medicaid became the first state in the country to authorize reimbursement for e-consults directly to federally qualified health centers. And as a result of that, we implemented a statewide, agency-wide e-consult program for multiple specialties. And we found that given the circumstance that we were in, we were not alone. There were many other health centers that had a similar challenge with regard to access and cost. And so we started offering access to our platform to other health centers and helping them to develop a connection and to share their consults with us. And we began recruiting a larger network of specialists licensed in different states when necessary to provide consult responses to those other practices. With regards to the discussion that was had initially about payment, we've implemented this now in organizations that have a largely fee-for-service reimbursement model. We've implemented them in organizations that are part of an ACO, and we've implemented them in models where in organizations that have a total capitation and risk-based reimbursement. And every one of them has found a slightly different way to manage, but all of them have been able to, or are able to, realize a return on investment in addition to meeting the needs of their patients more rapidly and more efficiently. And we've connected, we've been very pragmatic. We haven't insisted on anybody logging on or typing new information into a website. We've allowed them to e-fax, to email, to use P2P, remote access, anything that they needed to send the consult, and we return it back to them in the same way. And we call that entity Community eConsult Network. It's an affiliate of our health center. And we have developed an increasingly broad network of specialists that work with us to answer those responses and send them back to the primary care provider. These are the specialties that we added. We continue to add more on a regular basis as we continue to confirm the value of the e-consult in different specialties. Just this past week, we added rheumatology, and I've been reviewing rheumatology consults as they've been coming in, and it's been like manna from heaven for our primary care providers who in Connecticut claim that rheumatology is the hardest consult to get. The exchange of information and the exchange of knowledge and the education that's coming across. I read an e-consult from a rheumatologist yesterday. There was a mildly positive ANA in a patient with some vague symptoms, and the rheumatologist gave a tutorial to the primary care provider on the diagnosis of lupus and the appropriate clinical tests to order and questions to ask the patient. And I observed not only a face-to-face consult being prevented, but the primary care provider being educated about the workup of lupus that they will then apply to their next case. This summary slide is actually, although it's a boring data table with lots of numbers, this is the bottom line. And there is a patient story and a provider story behind these numbers that really demonstrates what can happen when you take this concept to scale. And I think the reason that we've been so focused on asynchronous is because of its scalability. And what you can see here is you look at the different numbers. Each specialty is different. But what they reflect is the total number of adult consults that we do in each of these specialties per year. CHC is a large health center. We have health centers, we have clinics across the state, and you can see, do about 11,000 consults a year. And orthopedics is our number one, followed by GI. You can see the number of those in the second column that were appropriate for an e-consult. We have a protocol that defines which consults should and should not be sent as an e-consult. And then you can see the number that didn't need a face-to-face, that the consult question was resolved electronically and what that percentage was. So if you go across for endocrinology, you can see that 39% of our total endocrinology consult volume is now being managed exclusively with an e-consult. For GI, it's only 6%, and the obvious reason for that is we do an awful lot of screening colonoscopies and procedures, which to this day can't be done as an e-consult. And orthopedics, I'll point out, even though it's only 19% of our consult volume is managed electronically, because the number of consults for ortho are so high, that is still a pretty significant impact on access and efficiency for our patients. 440 patients had an e-consult orthopedic review similar to the one that I just showed you. So I think to summarize, what we found our experience both in Connecticut and increasingly as we've expanded access to our e-consult platform to other similar practices is that really this is an intervention that achieves the quadruple aim and does it in 6 months or less. Immediately when you throw the switch and start exchanging e-consults, you get quicker and more efficient access to treatment, which improves the patient experience. You reduce face-to-face visits, you reduce tests and procedures, and save money. Clinicians are uniformly satisfied with this. It is no fun to manage a patient when you refer them to a specialist and it takes 6 months for them to be seen because they continue to call, they continue to come in. Sometimes they end up in the ER and you have to follow up on that. So this is wonderfully satisfying for clinicians, in addition to the fact that they're receiving these wonderful brief tutorials case by case, which is a wonderful way to continue to learn and stay current on all of the different topics and areas that we work in primary care. And we've improved patient experience extensively. Patients don't have to take days off from work. They don't have to get childcare. They don't have to arrange transportation to get to the Yukon Health Center from New Britain, which is only 10 miles away. You have to take 3 different buses. It is a big, big win for our patients when their case can be managed in their patient-centered medical home where they receive their care. So with that, I am going to say thank you. My email is here. I'd be happy to talk with anybody offline if there's questions. 2 of our websites for the Weitzman and for community consults are listed there as well. And with that, I will pass the baton.
Okay. So this is Julie Lynn. Can people hear me? I'm going to assume yes if I'm not getting a response.
Yeah, thank you, Julie. You're coming in loud and clear.
Okay. So I'm a dermatologist at the University of Vermont Medical Center. I specialize in medical dermatology and clinical informatics. I do have to disclose that I do work for a private company providing store and forward, and the company is Direct Dermatology, and I will speak briefly to that experience. And I'm going to talk about the experience of us trying to develop a store and forward telederm in the Vermont area. So just to give you a little bit of the background of our local landscape, we're the only academic medical center in the state. So we're the only NICU level 1 trauma center, and close to the national statistics. There are not a lot of dermatologists in the area, and we tend to be all concentrated in the Burlington area, in the immediate medical center, and the remaining dermatologists are in solo private practice throughout the state. So this is just a map of Vermont, and you can see here in gray, Chittenden County, this is where our medical center is. And all this gray and white here shows that there are no dermatologists in these areas, so there is one in each of these other counties. We also serve northern New York, which we share Lake Champlain with. As you can see here in New York, where we border the state, there's only one dermatologist here in the area. This whole area in white or gray, there's no dermatologist. So we are basically the dermatologist serving a large area. And it's not uncommon for patients to drive 3 or 4 hours to visit us. It's no different than the national workforce shortage, where basically all dermatologists nationally are looking to expand their practice. The mean wait time has been reported from anywhere from 1 month back in 2008. These are kind of samples of average wait times for patients nationally. In our area in Burlington, because we serve such a wide area and are located so locally, our average appointment for a new patient with no urgent concerns is 8 months. So I'm just going to start with also another case study or story to say why I personally feel that telederm, store and forward in our area would be a perfect fit to provide access. And this type of scenario is real, this happens, but this is not so uncommon to happen. It's a late Friday afternoon, our clinic is already closed, and a provider from the emergency room calls me and basically says, look, you need to help me. This patient has come back. This is the 3rd time he's seen a provider, and he's not getting better. He was diagnosed with a spider bite, given the antibiotic, returned to a different walk-in care, given a different antibiotic. And basically, as we're talking, I said, look, if you just send me a photo, I'm probably going to be able to give you more information. So he sends me a photo, and I look, and I said, look, I think this is Lyme disease. I think you should just give him some doxycycline, check a serology. I said, do you want me to come down and see the patient? He's like, no. And I said, well, why don't you just send him to the clinic Monday morning? So when I saw the patient Monday morning, the patient had just been discharged that morning from the hospital, and he goes to tell me that over the weekend, he developed a facial droop, left-sided weakness. He had a huge hospital workup and admission over the weekend to work up his left-sided weakness for stroke and everything. He had a lumbar puncture, a lot of imaging. And the rash that I had seen on the photo on Friday was barely there. However, when I logged onto the computer, his Lyme serologies had come back, and it was positive for a recent infection, as well as the cerebral spinal fluid. So basically, his whole host of symptoms was able to explain that he probably had CNM Lyme disease and palsy and left-sided weakness. What I learned from this is, one, it's very frustrating for the patient because he didn't have access to a dermatologist, and that's why he kept on going to urgent care, walk-in clinic, emergency room. And a lot of the skin diseases has a temporal diagnostic and treatment relationship. So if a referring provider makes a referral and they're not seen until 3, 4, or 5 months down the road, that rash might not even be there anymore or looks very different. The fact that I was able to see the image at the time the emergency room was led to an accurate diagnosis. And several providers just had failed to diagnose the typical bullseye lesion earlier in development. So basically, this all could have been avoided if the patient had access to dermatologists. The hospitalization could have been avoided that resulted in the increased costs of the health system. And more importantly, he could have avoided the sequelae of late Lyme disease. And you can't even account for his lost personal time and work of leaving work to go to these multiple visits because of and all the fear and frustration and anxiety that was associated with a persistent and unresolved medical problem. So this is when I decided, we wanted to try to offer store and forward, but we had no kind of infrastructure to just deliver it. So I looked, and our professional organization called the American Academy of Dermatology had developed something called Access Derm, which is a free teledermatology platform sponsored by the AED. It was designed to be a volunteer program that has to be initiated by a board-certified dermatologist, where you are able to basically securely send images with clinical information back and forth, either using a mobile device or a web browser, and has worked pretty well. It can be downloaded on a phone, iPad, or Android, or any web browser. Right now, there are about 16 states that are doing this. It's probably has expanded by then, where this has been actively going on. And this is just an example of what the login screen looks like on a mobile device, where a referring provider is given you're able to enter your information. So you take the photo directly from the mobile device. The photograph does not stay on the mobile device. And then there are some hard stop questions that you need to answer, which is generally a very basic HPI. When the consult is done and the dermatologist has answered the consult, there's a summary of the visit here where you have the photos, basically questions that are basically amount to an HPI, and then the bottom are the dermatologist's recommendation. So it does print out as a PDF. It is not the discrete data that everybody wishes for, but at least the summary that can at least be scanned into the patient's chart that memorializes the transaction. So when we set out to do this, we approached our primary care office in our health network that was the farthest away from us, that used the same electronic health record. And one of the things I will point out is if you decide to try to pilot this, you really need engaged providers on both sides. If it's something that an office manager just wants to organize, but the providers are not interested, I think it's exceedingly difficult. You really need the buy-in of the providers. When I'm speaking to them, we wanted to make the workflow as easy as possible. And unfortunately, because at that time, none of the providers had a smartphone or mobile device, and only the support staff and nurses did, the workflow was that if the primary care provider was in an office setting and they had a patient with a derm lesion, they would step out and ask their support staff and say, hey, I don't know what this is, can you get a derm consult? And they would, they had a pre-built template in their electronic health record that would answer the basic questions that was required, and they could just leave the room and move on to the next patient. And it was the nursing staff that would log on to the Access Derm mobile app, take the photos, and transcribe what was in the EHR back into the app and send the consult to me, that I would then receive either on my iPhone or a web browser that I could view at my convenience and send a response. And either way, when a consult is sent or received, there's an email alert or also a push notification to say that you have a consult waiting for you. Just in terms of workflow, one of the sticking points was, in the old days, it takes a long time to take a photo traditionally. If you take it from a camera, you've got a memory card that you have to also copy to a server and then upload. There's also the risk of this image on the memory card being lost or mislabeled. So part of the advantage of using a mobile device to acquire the image is there isn't that time to get the image off of it. And also it's more secure because the image is being saved directly on a server. So it's a difference between 5 minutes and 15 seconds, because if you want, with the Access Derm application, you can take a photograph with a traditional camera if someone isn't set up with the application. So when we did this, we approached the clinic, a primary care provider. There are about 12 providers and also a walk-in clinic. We looked at data at this clinic prior to what were they sending us, and this is just the pre-teledermatology. So this was administrative data of how long was it taking for a patient to get in when there's a derm request, and how many referrals were done. And then data here is post 8 months. We basically looked at the consults that came in. So it took us on average about 9 hours to respond to a consult, and of those consults where we felt a patient needed a visit, we were able to get them in under 2 weeks. So a difference between 2 months to 2 weeks, I think, was a significant difference. So for us, this was saying, yeah, this can work. You are providing better access for the patient. We also looked at what were they sending. There was a bias because when we initially did training, I did educate the providers that teledermatology is usually most appropriate for rashes and pattern recognition. And if you send a solid lesion, especially a brown lesion, it's really not that safe to make a recommendation based on a solitary photo, and those patients really should be seen in person. So the bias referral was that prior to dermatology, these were the type of diagnoses that the referring providers were sending us. This is purely that's just pulling ICD-9 codes. And then these were the diagnoses of the types of consults that were sent to us. Also, when we were just doing some analysis, we had to exclude some of the consults because there were some technology issues, which were learning points. So what we realized is we relied very heavily on the email alert and the push notification to know that there was a consult waiting. And if you didn't have that alert, there was a significant delay or lag in checking the consults, because you're logging into a separate system and people aren't going to be logging in, multiple times a day to see if there's a consult waiting. So some of those technology issues were that our internet hospital server decided to block the email alerts that would come through because they thought it was spam. Therefore, there was a period of several weeks where the consult alerts were not coming through. Another thing that was interesting is there was a question in the Access Derm that the primary care provider has to ask about if they thought the patient required an office visit. And this is similar to what the Weitzman Institute saw, is that of the 44 consults we analyzed, 23 of them thought that it required an office visit, but when the dermatologists actually evaluated it, we only thought 11 did. And again, I want to mention, this was purely a pilot and no money was exchanged hands. It was purely, everything was done on a volunteer basis. So just to think about, if you are thinking about doing store and forward teledermatology, I think you have to be kind of buyer beware, especially with a lot of the mobile applications. If you go to the iTunes store right now, there are now over 222 apps that are seem derm related. And there's one, this is reported from 2013, and only 8 really appear to be related to patient care. One is including the Access Derm. There are store and forward specific dermatology platforms. These were the 4 major players in the past. There are now so many that are available, promising to provide this. And in addition, there's also the VA health system, which probably has the biggest, most successful system available within that system. Also, a lot of commercial vendors, so existing EHRs, are now offering enhancements that also accommodate telemedicine workflows. I use the Epic system. They have an Epic consult encounter type. A lot of dermatologists in private practice use a software called Modernizing Medicine. They also are now building out specific telederm consults. And then there's also the tethered electronic health records. Most people know them as the patient portals, where the big commercial vendors of EHR, Allscripts, Epic, are allowing patients to send photos directly to the provider within the existing EHR. There's also now a lot of direct-to-consumer apps. And when you look, a lot of them are virtually identical. They're kind of branded to specific providers where it's the same platform that people have customized. And, it's unclear if these are providing a good care and kind of who's doing them. They're exponentially growing now, I think, by the month. So also, besides I talked about tethered EHR, we talked about the patient portals or embedded teledermatology functioning. What you need to realize is a lot of these teledermatology applications, they're not exchanging health information as discrete care. And you want to think about that if you're thinking about doing telederm, because you want to do everything possible to coordinate care and not fragment it more than it already is. So if you're using a standalone system, you want to really think closely about your workflow and how's the data flowing. Is everybody getting the right information? Is the patient being navigated through the health system in a friendly way? So most recently, the APIs that have been talked about, these are application programming interfaces. These are like kind of mobile applications that can potentially be embedded in a lot of these electronic health records, are rapidly being developed, and that's something you should think about or ask. Okay, so then I'm going to lastly talk briefly about my other personal experience working with a private company called Direct Dermatology, and I'm going to reference this article in JAMA here, where the RAND Corporation had written an article about them. So they provide store and forward and a little bit of direct-to-patient care teledermatology to the California Medicaid patients. And they initially were sending store and forward consults in a very traditional format, as I had just spoken about, where the dermatologist thinks a referring provider thinks a dermatology consult is appropriate. So they are acquiring the images and the clinical information in the office. And what this company realized was, primary care providers are busy. They don't want, it's just yet another thing for them to do. So they decided to offload that workload. So what they had were clinics nearby. Some were, in the Stop and Shop, like a Minute Clinic, where they would have dermatology staff there. So they would say, hey, John Smith, you have a derm problem. Why don't you go to this clinic across the street, and somebody there is going to take your photos and get some information from you. So then it was the dermatology staff that was acquiring the photographs and interviewing and getting the HPI, which turned out that the photos were of much higher quality and the information they were getting was much more comprehensive. The remote dermatologist would review the history and the plan, and it was the telederm staff that would relay the plan back to the patient directly, and the referring provider would get a letter. And that's also kind of the difference where they're shifting to say that they will take care of the whole continuum of care from start to finish. And after initial recommendations were done, the patient was asked to come back for a telederm follow-up consult, come back to the same clinic, get photos, retaken history. And then the same group of dermatologists doing the consults who were there locally also had a physical brick and mortar clinic. So if patients needed biopsies, procedures, or more complex cases, they would go ahead and arrange for the patient. So from the start, as soon as the referring provider realizes that there needed to be derm follow-up, the teledermatology service took over the rest of the service and coordination of care from then on, and there was not as much work for the referring provider. And I quite like this model because I feel like it's giving the patient comprehensive care. They're able to contact you directly and call them as you can, and there's a lot of staff and support to coordinate the care. So a lot of things you think about workflow, if you're going to think about trying a telederm model, is how do you want to deliver the care? Are you going to use a consultative model, which is the most traditional? Is it going to be purely for triage? Are you interested in direct-to-consumer? And are you interested in using it, say, for continuity of care? So if so dermatologists could even use it in their own practice, where you see a patient with acne and you prescribe a cream. Is there a reason why you really need to see them in person, or could this be done in a follow-up telederm consult? And you want to really think about, you want the visit to be equal or equivalent to an in-office visit. So you want to be, anything that happens normally in an office, you want to be able to replicate virtually. And instead of these kind of one and done transactions, or I send the consultant back and that's it, it's actually caring for the patient over the continuum, with some of these patients having chronic diseases. So you want to consider all the workflows that happen in a regular office and think about how can you deliver that virtually, and do you have the workflows and staff built in to be able to accommodate that. So for instance, if you get a consult received and you need more information, say you need an old path report, you need more labs or clinic notes, you know, who's going to get them? Are you going to ask the primary care doctor to do all this, or could you kind of provide that yourself? And if you get them, how are you going to view them? How are they going to be stored? Are you actually going to have them with a virtual parallel EHR, or is everything going to go in through the system? You know, if you need to contact the patient, again, say English is not their first language, do you have a translator service? Are you going to call them from your personal phone, and is it going to say, hi, it's Dr. Lynn, or is there a mechanism to call where it says, this is the office of the telederm consult? And there are a lot of technologies now available where you can call through a different, even through a mobile application to say, hey, this is Vermont store and forward telederm calling. So on the patient-facing side, it looks like it's an office versus someone's personal cell phone. If you're going to get a lab test, how are you going to get that to the patient? Do you have a mechanism where you can get them a lab slip and tell them, you know, what lab they need to go to? And also, you know, who are the people taking the clinical photos and history? Is it going to be the referring office? Is it something you're going to trust the patient to do, or are you going to have staff to do that? Also, you want to decide, you know, are you going to e-prescribe? And that really comes down to your local laws of the state. Every state has their own laws about what constitutes a physical exam, and does a teledermatology consult count. And also, most important thing is, if you see a telederm consult that you know that patient needs to be seen in person, you need to be able to get that person into a brick and mortar clinic. And how's that going to be done? Who's arranging it? Are you going to get a confirmation that the patient was actually seen? It shouldn't be on the onus of the patient to figure out how they're going to get to a dermatologist in person. And also, I think really importantly are alerts, because these happen asynchronously. You really need an alert whenever there's a message from a patient waiting for you, or if there's a result waiting, or if there's a telederm consult follow-up for you, because this is not something that you want to be logging on constantly during the day to see if there's something waiting for you. If you decide you're going to do follow-up care, how are you going to monitor patients and results? Or is there a way for labs to be viewed? And do you have a support staff that can support all this? And also, if you're asking for patients to come back for follow-up, if they're not showing up, you know, are you going to be alerted? So you're almost managing a virtual patient population or a virtual office. So hopefully this was helpful. I kind of gave some information about our experience locally and kind of my experience in California. And this is my email for those of you that want to ask me questions offline. So again, I want to thank the ACLU for giving me the opportunity to speak. And I think I'm going to send it over to the moderators.
Okay, well, thank you so much, Julie. Let's see, let me share my screen and we will go back. We're going to begin the Q&A portion, and which, Karen, means I'm basically going to hand it over to you to moderate. We don't have any questions at this moment, so I guess I'll just remind everybody that now is the time to send me those questions. Use that chat box at the bottom. And but Karen, I think you have sort of moderator's prerogative right now to begin with your own questions, and I'll interject as soon as I get some. Karen, are you there? Might be on mute, actually.
Yep. Mute is off.
There,
Sorry.
Yep, there you go. We hear you.
Thank you so much, and particularly thank you to Julie and Daren. A lot of amazingly strong information on both of the key issues that I think are on everyone's mind around cost savings, because there have been a lot of concerns that perhaps there haven't been appropriate cost savings associated with telehealth, but I think the kind of work that you're doing, Daren, is really laying those concerns aside. And then the other big issue, of course, is workflow. And I think, Julie, you have done an excellent job pointing out all of those issues around workflow as well. As the questions come in, I would also just like to remind everyone that telehealth is a very integral part to your HIT platform. I think in general, people think of HIT as being EHRs, the data that comes out of EHRs and other sources such as registries. And they also think about HIT in terms of sharing information. You all have to send information to, you know, I say you all, providers have to send information for meaningful use to public health using health information exchange standards. And there's the clinical care document that houses information as well. So much emphasis has been put on both the data generation and analysis and the health information exchange sharing modalities that folks tend to forget that telehealth is a very important third leg of the HIT platform that people should be thinking about as they go forward. I think we may have a few questions. So, Tom, do we have any coming in at this point?
We do have one, and the question is from Kurt, and it's to all the panelists. Well, actually, probably for Weitzman. How did Weitzman determine the protocols that define who's eligible for a consult? Was it by condition or lack of geographic access?
Thanks, Tom. That's a great question, and I'd be happy to share a copy of what one of them looks like. Really, it was based on clinical grounds, and the protocols that we develop are created jointly by the specialists and the primary care providers, usually the medical director of the organization, and they're fairly broad in that, I'll give you one example. Our endocrinology protocol states that well, there's two parts to it. The first part is it just describes what types of information the reviewing endocrinologist wants to receive from the primary care provider in order to review the consult. And the second part of the protocol lays out what types of consults should not be sent as e-consults. And for endocrinology, any urgent consult, any consult with for a patient who already has an established relationship with an endocrinologist and they want to go back to see them for a follow-up. And the third is anything obviously related to a procedure, and in endocrinology, it's fine needle aspirate. And then lastly, anything relating to insulin pump settings and adjustments. Those are the 4 exclusion criteria that we created for endocrinology here in Connecticut for our providers. Cardiology excludes obviously urgency again, and patients who clearly need a procedure and are being referred for such. For gastroenterology, other than the urgency and established relationship, it's any patient who needs a GI procedure. So they're fairly broad. So if you look at that chart that I presented, the vast majority of patients who are excluded and not sent as an e-consult are because they're being sent for a specific procedure. In dermatology, another exclusion is when patients are being sent not to evaluate a rash, but we have some patients that go for total body checks because they have a high predilection for skin cancer, things like that. So they're pretty common sense exclusions, and we've set it up that the protocol is in place and the e-consult is the default. So unless the primary care provider says otherwise, consults that meet those criteria and aren't part of the exclusion criteria are sent first as an e-consult, and that's part of the way we've been able to generate the numbers and the impact across our large health system.
Okay, great. Thank you for that, Daren. Julie, sorry, I have another question, and the question is for Julie. Julie, you mentioned a system whereby a dermatologist is notified that they have a message waiting. Is there a way that the physician who sends that message can be notified that that message was actually received and is being tended to? Is there any functionality there?
So, not that I'm currently aware of. So it's almost like a patient portal where the patient can email the referring dermatologist. What the referring provider gets is a copy of any time there's an encounter. So if they reply and I say that I have recommendations and I'm going to do something, they get a copy of the note. But I don't think that that system, the referring provider logs in. But I can't be sure, not being on the other side. They're typically not in there kind of messaging the patient or the provider.
Okay. Daren, did you have a comment there?
Oh, sorry.
Okay, sorry. I thought I heard you, Daren.
Are there any other questions at this time, Tom? We have a few more moments.
Yeah, no, I think no questions right now, so I'll give it to you.
Oh, great. Thank you. I actually have one for perhaps both of you, but I'll direct it to Julie first. And it has to do with the importance of timeliness. I mean, some things obviously can wait for a period of time, as you've said. But do you have some indication, or do you do any education with the providers that refer on to you on the types of things that really shouldn't wait and should be referred on to you fairly quickly?
So with every diagnosis, we have the ability kind of to attach patient education information that the referring provider also gets about the condition. But usually when you start a service with a new office, usually there's a lot of face-to-face education of how to take a photo, what is appropriate for, and generally kind of a little bit of a list of like, this is what's urgent, this is what's not. And ideally, the best type of telederm service is kind of almost like the ECHO model, or at least you meet on some ongoing basis to review the cases that have been referred to say, hey, you sent us so many cases of vasculitis this month, and this is what we've recommended, kind of giving some kind of teaching or pearls about that. So they may not need to refer similar diagnosis in the future because they're recognizing it, now know how to manage it and diagnose it.
That's an excellent point that I think you made. Do you do that as well, Daren, with your program?
Yeah, I wanted to echo those comments about a Project Echo-like intervention. We are developing, as we speak, a video conference modeled after Project Echo. We didn't talk about Echo today, but we do have several Project Echoes in several different areas. But this one would be different in that it would be for all users of the e-consult system. And as was already suggested, the specialist would cull through the cases they're seeing and identify commonalities and common conditions, common questions, and then present in more of a grand rounds type format some selected cases and a didactic about that topic. I think it's a really great way to leverage all of the information and use it to improve knowledge. Because I didn't share it, but we have data showing now that over time, the total consult volume submitted by primary care providers goes down when they start doing e-consults, which suggests to me that they are in fact learning and applying the lessons they're learning from their e-consults, and as a result, they're requiring fewer consults over time, which I think is a really exciting finding. In terms of the other aspects to your question, our e-consults are turned around in 24 hours, 48 maximum, but our average response from our specialists is same day. So I think it's interesting, even we could debate this, but there aren't that many truly urgent consults in primary care. If somebody has something truly urgent, generally they go to the ER. But even in cases of relatively critical questions that need to be addressed, we find that the e-consult sometimes helps to expedite their access to specialty, because you've had a specialist look it over and tell you, this is quite urgent, you should really work to get this person in. So it allows you to apply your limited resources or call out that favor, whatever you need to do to get that person in and seen sooner. And if I could just share my screen for a second, just in relation to the previous question, I'll show you what a clinical protocol looks like. So, as I said before, they're relatively broad. An urgent stat complaint is one of the exclusion criteria, but this is a pediatric pulmonary consult protocol, and it lists the 6 core things that the pediatric pulmonologist would like to have included as part of the consult. And it has the 6 exclusion criteria. Growth chart should be up on the top. That's something to be included, not an exclusion criteria. Urgent stat, adult patients, anybody being referred for a pulmonary function test, or patients with an established relationship with a pediatric pulmonary specialist. Those are the exclusions. Everything else, unless there's a reason that's not included here that the primary care provider indicates, those are the reasons to exclude and not to send it as an e-consult.
Thank you, both of you, for responding to that. We are almost at the top of the hour, so again, I would like to thank both of our presenters today, and I hope that you have come away with at least a very strong appetizer that will make you perhaps more interested in exploring not only the concepts of asynchronous telehealth, the store and forward in your own practices in your own as you pursue accountable care, but also to think a little bit more about the overall picture of the HIT platform as you're building it going forward. So this is going to be, I think, a very important aspect to HIT going forward, telehealth in general, and you've had they say a strong appetizer, but there's a lot more in the whole entire telehealth program and picture to think about going forward. So as you do your HIT platform, don't forget to include that important leg of the stool. So Tom, I guess we're just about there at the top of the hour. And thank you so much to Levitt Partners for allowing this group to present its exciting research and all the good work that it's doing in the field.
It was a great group. Thank you so much, Karen, to you for moderating, and especially to Daren and Julie for being willing to join us today and share some learnings and some really great data and frontline experience from what they're doing. So just a reminder that an audio recording for today's session will be made available in the email that goes out weekly, along with the PowerPoint, so you can review that. Our guests have made themselves graciously available, and so we encourage you to reach out to them if you do have questions. They just have a lot of great experience. The next webinar will be on June 20th, and we will be taking a deep dive into June 21st. May 31st, excuse me, the political webinar. Sorry, the next sort of ACO topic related webinar will be June 20th, and that will be a deep dive into Medicaid ACOs, actually the Colorado state program in particular. So very excited about that. Thank you all for being on, and we will speak with you soon. Bye, everybody.
Thanks again. Bye, all.